Bismillahirrahmanirrahim. So now we're going to talk about the seronegative spondyloarthritis, uh, which which are formed by this mnemonic pair. So the P is for the psoriatic arthritis. It is associated with the skin psoriasis and nail lesions, asymmetric and patchy involvement. Dactylitis and pencil in cup deformity will be seen on the distal interphalangeal joint on X-ray. So in the distal interphalangeal joint, you can see this is the pencil in cup. Like this will become tapered off at the edge. So we will find a pencil in a cup appearance in the distal interphalangeal joint in the psoriatic arthritis, seen in fewer than one-third of the patient with psoriasis. Okay, so psoriasis is basically a condition in which the patient develops a plaque with a scaly patches, and in one-third of the patient with the psoriasis, the patient can develop this psoriatic arthritis as well. So here you can see a classical picture of psoriatic arthritis with a pencil and cup appearance. So this is the pencil, and then here we have the cup. So pencil and cup appearance. Then I guess this is the picture of that. So let's move forward. Ankylosing spondylitis. Ankylosis, joint fusion, symmetric involvement of the spine and sacroiliac joints. There will be bamboo spine, vertebral fusion. So when the vertebrae fuse together, so this looks like a bamboo stick or a bamboo pillar. So here you can see the body of vertebra and disc in a normal spine. Inflamed joints, as can be depicted here, and then that inflammation results in the fusion of the bones that result in the bamboo spine. Bamboo touching bone, bone touching bone, and this is ilium, sacrum, unaffected side. So on the affected side, you can see that the bone is touching the bone over here, while it is not touching it on the unaffected side. So what happens here, that ankylosis or the joint fusion, that is symmetric involvement of the spine and sacroiliac joints, will cause bamboo spine by vertebral fusion. Okay, the presentation, more common in males who are less than 40 years of age. Systemic symptoms include fever, chill, fatigue, and weight loss. Skeletal symptoms are low back pain, insidious onset and improves with the exercise but not with rest. Patient at night with morning stiffness. Okay, so there will be pain at night with the morning stiffness, and there is insidious onset, improves with exercise but not with rest, and pain at night with morning stiffness. Hip and buttock pain. Enthesitis, which is inflammation at the site of insertion of a tendon or a bone on the bone. Extraskeletal symptoms and complications. Respiratory and cardiovascular complications may be seen along with the complications in the eyes. So respiratory complications are restrictive lung diseases due to the limited chest wall expansion, costovertebral angle and costosternal ankylosis. Cardiovascular, the most common cardiovascular complication of ankylosing spondylitis is ascending aortitis, which can lead to dilation of the aortic ring and aortic insufficiency. Then we have eye. Anterior uveitis develop in some patients with the ankylosing spondylitis and present with painful red eyes, blurred vision, photophobia, and conjunctival erythema, as you can see over here. Conjunctival erythema. Uveitis is the inflammation of the uvea, the pigmented layer that lies between the inner retina and the outer fibrous layer composed of sclera and cornea. The uvea consists of the middle layer of pigmented vascular structure of the eye and include iris, ciliary body, and choroid. Here you can see the ankylosed sacroiliac joint in which the sacrum and the ilium are fused together. Here is the picture of bamboo spine. Then I guess this is ankylosed cervical vertebra over here, and this is the picture of uveitis in which you can see the erythema of the cornea. Along with that, you can see what else can you see? That is a red eye and yeah, stuff like that. Inflammatory bowel disease. So we are in the mnemonic pair. We are done with the psoriatic arthritis and ankylosing spondylitis. Now we are talking about the inflammatory bowel disease, and then we'll talk about reactive arthritis. In the inflammatory bowel disease or IBD, Crohn's disease and ulcerative colitis are often associated with the spondyloarthritis. Reactive arthritis, formerly known as the Reiter syndrome. Pathophysiology. The clinical manifestations are caused by the immune complexes involving bacterial antigens. Joint aspirates are sterile. It is a reactive, not infectious arthritis. Presentation. Preceding infection, genitourinary infections can cause chlamydia, enteritis, Shigella, Yersinia, Campylobacter, and Salmonella. And Shigella, Yersinia, genitourinary infections include chlamydia and enteritis. Okay, so preceding infection, if the reactive arthritis is following genitourinary infection, so most common infectious agent was chlamydia. If enteritis is preceding the reactive arthritis, in that case these are the organisms: Shigella, Yersinia, Campylobacter, and Salmonella. So shy chicks, Shigella, Yersinia, Chlamydia, Campylobacter, and Salmonella. Classic triad: conjunctival urethritis, arthritis, and conjunctivitis. Okay, conjunctivitis, urethritis, and arthritis, which means the person can't see, can't pee, and can't bend my knee. Moving forward, we are going to talk about keratoderma blanoregicum. Keratoderma blanoregicum, meaning keratinized skin, mucosae discharge. Okay, so blano means mucosae and discharge is regia means discharge. So keratoderma means keratinized skin, and blanoregia means mucosae discharge are skin lesions commonly found in the palms and soles, but which may spread to the scrotum, scalp, and trunk. The lesion may resemble psoriasis. The appearance is usually a vesicopostular waxy lesion with a yellow-brown color. These lesions may join together to form large crusty plaques with the discriminating edges. What is reactive arthritis? The preceding infection for the reactive arthritis is genitourinary infection, which may be caused by the chlamydia trachomatis, and enteritis, which is caused by salmonella, shigella, yersinia, campylobacter, or clostridium difficile. Musculoskeletal involvement of the reactive arthritis include asymmetric oligoarthritis, enthesitis, and dactylitis. Extra articular symptoms are ocular can cause conjunctivitis and anterior uveitis. Genital symptoms include urethritis, cervicitis, and prostatitis. Dermal include keratoderma blanoregicum, the one explained over here, and succinate balanitis and oral ulcers. So that is the succinate balanitis, and we will keratoderma blanoregicum. If there's a picture, there's no picture of that, so let's see a picture over here. Keratoderma. Okay, give me a second. Keratoderma blanoregicum. So keratoderma blanoregicum is basically a condition in which we find, that's one and the same thing, maybe. Okay, so keratoderma blanoregicum, these are waxy skin lesions, waxy keratinized skin lesions. Okay, so blanitis circinata or the circinate balanitis, serpiginous annular dermatitis of the glans penis. So this is balanitis circinata, the most common cutaneous manifestation of reactive arthritis. So this one is keratoderma blanoregicum, this one is keratoderma blanoregicum, and this is balanitis circinata on the glans penis. Then we have gout. Findings: acute inflammatory monoarthritis caused by precipitation of monosodium urate crystals. So it is monoarthritis that is involving only one joint and caused by the precipitation of monosodium urate crystals in the joints. Crystals are needle shaped with negative birefringence under the polarized light, yellow under parallel light, blue under perpendicular light. So if there is a picture, so yes, here you can see under parallel light they will be yellow, and under perpendicular light they will become blue. So that is negative birefringence. Negatively birefringent, which means under parallel light they will be yellow, and under under the perpendicular light they will appear blue. Risk factors: male sex, hypertension, obesity, diabetes, and dyslipidemia. Strongest risk factor is hyperuricemia, which can be caused by underexcretion or overproduction. The underexcretion of the uric acid, which is seen in 90% of the patients, can be idiopathic mostly, or can be due to the renal failure or medications. For example, the thiazide or loop diuretics, the salicylates, ethambutol, and alcohol. Overproduction of the uric acid, 10% of the patients, can be a primary gout. Primary gout is idiopathic. Myeloproliferative or lymphoproliferative disorders, in which there is so much proliferation of the tumor cells and so much lysis of the tumor cell accompanied by that, and that leads to excessive production of uric acid. Then cell turnover, for example, tumor lysis syndrome, if we are giving some chemotherapy, and Lesch-Nyhan syndrome, PRPP excess, or von Gerke disease. So these are the conditions in which we are finding the overproduction of these things. Uric acid. Pathophysiology: uptake of urate crystal by the neutrophils lead to free radical release, cytokine production, and joint inflammation. Symptoms: there is a difference in the symptom between acute and chronic gout. So in acute gout, we'll find arthritis, asymmetric joint distribution, joint is swollen, red, and painful. Okay, classic manifestation is painful metatarsophalangeal joint, MTP, of the big toe, that is called as podagra. So classic manifestation is a painful metatarsophalangeal joint of the big toe or the first toe, that is podagra. Acute attack tends to occur after a large meal with food rich in purines, for example, the red meat and seafood, trauma, surgery, dehydration, diuresis, or alcohol consumption. Alcohol metabolites compete for the same excretion site in the kidney as uric acid. That is very important, that alcohol metabolites will compete for the same excretion site in the kidney as the uric acid. So the uric acid excretion will be decreased. Decreased uric acid secretion and subsequent buildup in the blood, and that will result in acute gout episodes. What is chronic gout? Chronic gout is associated with the tophus formation and renal failure. Tophus is white, chalky aggregate of uric acid crystal with a fibrosis and giant cell reaction in the soft tissue and joints, often on external ear, olecranon bursa, or Achilles tendon. So what is tophus? If you could see in the picture, this is tophus. So tophus most commonly is found in the olecranon bursa or Achilles tendon or external ear, but it can form elsewhere. The white chalky aggregates of uric acid crystal with a fibrosis and giant cell reaction in the tissue. So that will be the microscopic picture. On gross pathology, you can find something like this. So this is tophus. Coming back, renal failure, urate crystal may deposit in the kidney, will lead to urate nephropathy. Treatment of gout in acute. First line treatment is NSAIDs, for example, indomethacin and glucocorticoids. Second line is colchicine. Chronic or preventive is xanthine oxidase inhibitors, for example, allopurinol and febuxostat, probenecid and pegloticase. Okay, acute gouty arthritis, let me zoom it in. So in this case, you can see that sign and symptoms are usually involves first metatarsophalangeal joint or knee, swelling, erythema and exquisite tenderness. Symptoms develop rapidly over 24 hours. Diagnosis: joint aspiration shows needle-shaped negatively birefringent crystals. Treatment is NSAIDs, non-steroidal anti-inflammatory drugs, for example, naproxen and indomethacin, preferred if no contraindications, and colchicine used as a second-line therapy. Then we have causes of gout. Okay, here you can see the causes of gout. Increased urate production. Primary gout is idiopathic, myeloproliferative and lymphoproliferative. Okay, so the causes of gout include primary gout, that is idiopathic, then myeloproliferative or lymphoproliferative disorders, tumor lysis syndrome, hypoxanthine guanine phosphoribosyl transferase deficiency, it is HGPRT deficiency, and decreased urate clearance, that is chronic kidney disease or thiazide loop diuretics. Okay, so we're done with the gout, I guess. Then the calcium pyrophosphate deposition disease, that is pseudo gout. So gout and pseudo gout are different conditions. In the gout, we have uric acid crystal deposition, and in the case of pseudo gout, we have calcium pyrophosphate deposition disease. The deposition of calcium pyrophosphate crystals within the joint space. Crystals are rhomboid and weakly positively birefringent. So the crystals in the case of gout, they were needle shaped and negatively birefringent. In the case of pseudo gout or calcium pyrophosphate deposition, the crystals are rhomboid and weakly or positively birefringent under the polarized light, blue when parallel to light. Okay, so the gout is yellow when parallel to right, and the opposite of that is true for the pseudo gout, that is blue when parallel to right. Remember the gout and remember the pseudo gout is opposite to that. Okay, and needle shape. So in the gout you find needle shaped crystals. So needle looks something like this, and that is negative birefringence as well. So the needle is for the negativity in the gout, and rhomboid looks something like this. So rhombus is, okay, give me a second. Rhombus is a structure like this. There's no, okay, rhombus looks something like this. If you join the edges of rhombus, it will become positive like this. So the calcium pyrophosphate deposition disease or pseudo gout is positively birefringent, while the gout, the original gout, that is negatively birefringent. And what does it mean? That in the case of gout, the parallel light, when it is passed through these crystals, in the case of gout, the proper gout, they will become yellow, and in the case of pseudo gout, they will become blue. Etiology: usually idiopathic, sometimes associated with hemochromatosis, hyperparathyroidism and joint trauma. The blue P's, blue when parallel, positive birefringent, and calcium pyrophosphate pseudo gout. So these are 4 P's which help you remember the pseudo gout, that is blue when parallel, positive birefringent, calcium pyrophosphate and pseudo gout. Presentation: occurs in patient more than 50 years of age, both sexes affected equally, pain and swelling with acute inflammation, that is pseudo gout, and or chronic degeneration, that is pseudo osteoarthritis, knee most commonly affected joint. Investigations: chondrocalcinosis, cartilage calcifications on X-ray. Treatment is with the acute treatment NSAIDs, colchicine, glucocorticoids and prophylaxis. And okay, so acute treatment with NSAIDs, colchicine and glucocorticoids, and prophylaxis is with the colchicine. So these are the blue crystals by the parallel, after the parallel light is passed through them, And then what is it in this picture? So these are synovial fluid aspirate and calcium pyrophosphate CPPD. What's that? D, what's D? Okay, so these are crystal. Okay, so if you could zoom it in, so these are rhomboid crystals and axis of slow vibration, blah blah blah. So calcium pyrophosphate deposition disease. Okay, that is CPPD, calcium pyrophosphate deposition disease.